We were very pleased to present two posters at this year's ASH conference. The first one was looking at the real-world utilization of bispecific antibodies for the treatment of relapsed refractory multiple myeloma, specifically in the community oncology setting. The first bispecifics were approved in 2022, and since then there are now 3 therapies that are available and preferred treatment options after at least 4 prior lines of therapy for relapsed refractory multiple myeloma. But despite these therapies being approved and preferred, there's really limited real-world evidence about how these are being used, who they're being given to in the real-world practice, and specifically in the community oncology setting, where there are some considerations for the safe administration, both clinical and operational resource demands that the administration of these therapies takes. So we did a retrospective observational study using our iKnowMed electronic health records data, looking at the uptake of bispecifics and doing some descriptive statistics to compare the patients who did and did not receive bispecifics. And we had a sample of about 564 patients, and we found that since the first approval in October 2022, there was quite rapid uptake of bispecifics and continuing uptake over time until the point of our data cutoff, which was in July of 2024. So very promising results, this rapid uptake. We also looked at the patient characteristics and found that the patients receiving bispecifics tended to be a little bit younger and tended to have better performance status than those who did not receive bispecifics. This was descriptive, directional only, but kind of in line with expectations when new therapies get put on the market. These are the patients we would expect to see, and as practices become more familiar and comfortable with these therapies, we're expecting that to shift a little bit more. And so I think what the study highlights as a whole is it's really promising that we're seeing this quite rapid uptake, even in the community setting, because they are difficult to administer. It's difficult to monitor patients receiving these treatments, and yet the practices are making it happen. And so we're excited to continue monitoring the uptake and deep diving into the patient characteristics a little bit more once we have a bigger sample size, as well as better understanding potential barriers to continued utilization or uptake as well. I think there's a lot of long-term potential for integrating these into just the standard of care for certain patients, and being able to achieve really promising outcomes with bispecific therapies, especially as patients are more comfortable with therapies, and especially the practices as well. So as they develop their playbooks, their best practices as well, being able to more widely administer these kind of treatments just as standard. So the second abstract, our second poster, was around trends in patient characteristics and outcomes for diffuse large B-cell lymphoma, so DLBCL, pre and post CAR-T approvals. And so we have access to a very large network of practices, community oncology practices, and their EMR data. And so we pulled about 15,000 DLBCL patients, and we described their characteristics before the approval of the first CAR-T agent and after the approval, so kind of a time trends analysis to try to understand, are there fundamental shifts going on in the DLBCL patient population? We did not find really any major differences in the pre and post CAR-T eras. The absolute number of patients has grown over time, which is likely reflective more of just increasing practices participating in the network and in our database. But there really weren't major differences in the patient characteristics. We also took a preliminary look at some outcomes, so 1 and 2 year survival rates, and we did not pick up a significant signal or difference in the pre and post CAR-T eras either. But I think that's also not entirely surprising, because we did not compare CAR-T to no CAR-T patients specifically. We looked at all of the patients. And so the actual use of CAR-T may still be limited for us to be, too limited for us to be able to pick up that signal just yet in the survival rates. So as we get longer follow-up, we'll redo that analysis. We'll look at differences in survival outcomes. And then as a next step of the study, we're also wanting to deep dive into actual patients receiving CAR-T and those who did not receive CAR-T to do a more direct comparison once that data is available.